Hello and welcome. My name is Dr. Sherif Negm. I'm a professor of obstetrics and gynecology at Cairo University, and today I'll be talking to you about non-neoplastic cysts of the ovary and benign ovarian neoplasms. The non-neoplastic cysts of the ovary, these are enlargement of ovary, is one of the most common gynecological conditions encountered in clinical practice. Ovarian cysts could be either non-neoplastic or neoplastic in origin. Non-neoplastic cysts of the ovary are by far much more common than neoplastic cysts. The non-neoplastic cysts of the ovary include follicular cysts, corpus luteum cysts, THECA lutein cysts, endometriotic cysts, inflammatory cysts, germinal inclusion cysts, and polycystic ovary. We'll talk about many of these in the next few slides. The first is the follicular cyst. This is the commonest non-neoplastic cyst of the ovary. This may arise either from a cystic overdistension of an atretic follicle or a dominant Graafian follicle that failed to rupture. And as you can see here, this is a schematic diagram. You can see here the fallopian tube, and you can see the ovary with a large thin-walled cyst that has clear fluid inside. This is the appearance of a follicular cyst, and it is usually small, less than 5 to 6 centimeters in size. Pathology, as we said before, it is usually single and unilateral, usually small in size, less than 7 centimeters, and is unilocular and contains clear fluid. The cyst wall is thin and lined by granulosa cells. The clinical picture, most cases are asymptomatic and are discovered accidentally. The patient is having an examination or doing an ultrasound. Sometimes it results in menstrual disturbance if it is functional, resulting in delay in the menses from its expected time. Rarely it may result in pain. Sometimes it may be acute pain if the ovary harboring the follicular cyst undergoes torsion or hemorrhage. Diagnosis, rarely it can be diagnosed by abdominal or by manual examination if the patient is thin, but most commonly we usually depend on transvaginal ultrasound or abdominal ultrasound. And this is the gold standard for diagnosis. And as you can see here, this is the ultrasound appearance of what is essentially a functional follicular cyst, which appears as a thin-walled anechoic clear cyst with no septi inside, usually less than 7 centimeters in diameter. And the usual treatment is we just follow them up unless the patient is in acute pain, and they usually subside or resolve spontaneously without in any interference. A corpus luteum cyst, this is the second most common non-neoplastic cyst of the ovary, and they arise from excessive hemorrhage in size, the corpus luteum, during the stage of vascularization. They most commonly occur during the childbearing period, of course, which is the time when ovulation occurs, and may sometimes occur in association with early pregnancy. Pathology, the cyst itself is lined by luteinized granulosa cells, and it is usually lateral and single. A unilocular cyst, small in size, 3 to 7, but contains either bloody fluid or clear content. It should be differentiated from a follicular cyst, and as you can see here from this slide, the image on top, the video, this is a hemorrhagic corpus luteum, and you can see the characteristic internal echo pattern, what is known as a honeycomb or fishnet appearance, as compared to a follicular cyst which has a anechoic clear content inside. It should also be differentiated from other causes of pain in the right iliac fossa, such as appendicitis, renal colics, or ectopic pregnancy. THECA lutein cysts, these commonly arise due to ovarian hyperstimulation in patients undergoing in vitro fertilization due to the large amounts of pituitary gonadotropins given to these patients. So instead of the patient having a single dominant follicle growing, a whole cohort of follicles are recruited, and all of them are converted into corpus lutei, resulting in multiple THECA lutein cysts, and it may sometimes occur spontaneously, but more commonly occurs due to uh, ovarian hyperstimulation. The pathology, the ovary is usually markedly enlarged, containing multiple bilateral cysts, bluish in color, and the ovary itself may reach a very large size, more than 20 centimeters in some cases, and it is lined by luteinized THECA cells. The fate and complications, the majority undergo spontaneous regression whenever HCG levels fall. Less commonly, the cyst may undergo ovarian torsion or hemorrhage, and the condition can be diagnosed mainly by pelvic ultrasonography. As you can see in this video loop, you can see this is a transabdominal ultrasound in a patient who has ovarian hyperstimulation because she has taken a large amount of gonadotropins and she had polycystic ovary. You can see here, this is the uterus. You can see the uterus there. This is the uterus. And these are the enlarged, bilaterally enlarged ovaries with multiple THECA lutein cysts. And because the condition was severe, you can see that also there was acidic fluid filling the abdominal cavity. Another very common non-neoplastic cyst of the ovary are endometriotic cysts. These are, as we said, are not uncommon, especially with infertility and pelvic endometriosis. Pathologically, these cysts consist of cysts that are lined by endometriotic tissue, glands, and stroma, and they usually have a relatively thick wall, and they are usually surrounded by adhesions, and as a result, torsion of these cysts is highly unlikely to happen. On cut section, you can see that they contain what is known as chocolatey material, and this is actually retained blood which is accumulated within the cyst by time. And of course, this blood comes from the repeated menstruation with the monthly menstrual, but the blood or monthly menstrual flow. But because the endometrial tissue is trapped inside the ovary, the blood is also trapped inside the ovarian tissue, gradually forming this cystic structure, which is filled with this chocolatey material. My time, the serous fluid, the serous element of the blood becomes absorbed, and the blood becomes much thicker, resulting in the characteristic chocolatey appearance. The clinical picture and diagnosis. The patient usually gives a history of infertility is encountered in a significant group of patients. Sometimes the patient may also complain of severe dysmenorrhea or severe dyspareunia, and this is very characteristic of patients of endometriosis. Also, there's dull aching pain, as we said, associated with dysmenorrhea. On examination, sometimes if the patient is thin and cooperative and an excess mass can be palpated, nodules and tenderness over the uterosacral ligament sometimes may also be. But the mainstay of diagnosis is by transvaginal ultrasound, and you can see here from this video loop, you can see this is a transvaginal ultrasound, and anteriorly here you can see the uterus, and behind it here you can see the endometriotic cyst. And if you look carefully at the echo pattern or the structure, the internal structure of the cyst, this is known as the characteristic ground glass appearance of the cyst, which is very, very characteristic and diagnostic of endometriotic cyst. Of course, because there is inflammation of the peritoneal tissue and the ovary, this results in elevation of CA125. The levels may be quite high, although not as high as in cases of ovarian epithelial cancer. Laparoscopy is also very helpful because it is the gold standard for diagnosing endometriosis, and it is very helpful in both diagnosing and treating if treatment is an option of treating endometriotic cyst. You can see here from this image. This is a laparoscopic view. You can see the uterus here, and on its left side, You can see this endometrioma, the large endometrioma or chocolate cyst, and here you can see another image with the chocolate cyst being opened and the chocolatey material or the retained blood coming out of it. The treatment, if you have superficial ovarian lesions, these can be vaporized, as you can see here on this superficial lesions, which appear on the lateral pelvic wall or may be present on the surface of the ovary. Small endometriomas less than 3 centimeters can be aspirated, irrigated, and the anterior wall vaporized, or large endometriomas more than 3 centimeters may require surgical removal of the cyst to prevent recurrence. However, a word of caution, surgical treatment for endometriomas in patients complaining of infertility is now frowned upon and considered not as an option, because if you try and remove the endometrioma, this will result inadvertently in damaging the rest of the ovary, reduction of the ovarian reserve and ovarian antral follicle count. So current management recommendations in patients complaining mainly of infertility, even if they have moderately sized endometriomas, is to leave the endometriomas intact and not to touch them, and to manage the patient without draining the endometriomas. Surgical treatment for endometriomas should only be performed for patients complaining of severe pelvic pain or patients with infertility who have a very large endometrioma, preventing access to the ovary if the patient is going to have an IVF procedure. Inflammatory cysts of the ovary, these usually happen in the form of a tubo-ovarian cyst or tubo-ovarian abscess, and the infection may reach the ovary either by lymphatics or from a nearby infected organ. And here you can see a diagram of an infected ovary and this elongated cystic structure filled with pus. This is the tube. This is known as a tubo-ovarian complex or tubo-ovarian abscess, and you can see here it is opened, this same tubo-ovarian abscess, and you can see the thick wall with pyogenic membrane covering the inner surface and pus filling the cavity. Clinically, of course, since it is an inflammation, it is usually bilateral because both tubes are connected by lymphatics, and any infection in one tube usually will affect the other, and the infection, that is why it is usually bilateral. The patient usually presents with a history of recent delivery or abortion or recent surgical pelvic operation or IUD insert. Germinal inclusion cysts, these are microscopic cysts that result from invagination of the germinal epithelium into the substance of the ovary near or after menopause. Previously, they are considered of no clinical importance, but now they are regarded as forerunners of ovarian epithelial cancer. So what management options do we have for patients for non-neoplastic ovarian cysts? We can have either conservative management, we just wait and see what happens, because most of them just disappear spontaneously, medical treatment, and surgical treatment. Conservative management for small non-complicated functional cysts of the ovary, these are managed conservatively since spontaneous regression is the rule in the majority of cases. During the first few weeks of follow-up, ultrasound is usually used to monitor complete resolution. Medical treatment, gestogens and oral contraceptive pills may accelerate regression of follicular, corpus luteum cysts, and THECA lutein cysts by inducing ovarian quiescence and avoiding ovulation until the cysts or functional cysts have resolved completely. GnRH agonists, gestogens, and oral contraceptive pills may also help minimize the rate of growth of endometriotic cysts by inducing a state of artificial menopause, resulting in atrophy of the endometriotic deposits in the pelvis and shrinking in the size of the endometriotic cysts. Antibiotics, of course, are the treatment of first choice for patients with tubo-ovarian abscesses. So if you have an inflammatory cyst or ovarian abscess, then antibiotics and surgical drainage may also be an option. Surgical treatment: if you have a large cyst more than 7 centimeters, complicated cyst by hemorrhage or torsion, or persistently growing ones like endometriomas, as we said before, these can be managed surgically from the start or after an adequate interval of trying conservative treatment. Because the majority of cysts that are larger than 7 centimeters are usually not functional but may be benign uh, uh, non-functional benign neoplastic cysts of the ovary. Of course, the management may be open or laparoscopic, and this mainly depends upon the availability of equipment and the expertise of the surgeon. But in general, laparoscopic surgery is preferable to open surgery because laparoscopic surgery or keyhole surgery has many advantages. Among them is a shorter operative time, less incidence of pelvic adhesions, and a shorter hospital stay for the patient, and a quicker return to normal activity and normal ambulation. The cyst may be managed by either cystectomy, which is removal of the cyst if possible, or oophorectomy if the cyst is complicated, especially by torsion, and it has become completely necrotic. The parovarian cysts, these are not ovarian in origin. They actually arise from cystic dilatation of remnants of the Wolffian ducts in the tubule of the FO forum between the layers of the broad ligament just below the fallopian tube. These are small to moderately sized, rarely exceeding over 10 centimeters in diameter. They are covered by peritoneum with the fallopian tube characteristic stretched over them, their upper surface. They are usually thin-walled unilocular cysts lined by flattened epithelium, cuboidal epithelium, and contain clear fluid, and they do not tend to be malignant. They do not tend to be malignant. You can see this is a picture taken at the time of laparotomy. You can see here, this is the abdominal wall incision, and you can see this is the fallopian tube stretched over this cystic structure. This is a very characteristic appearance of the parovarian cyst, and it can be removed by making a small elliptical incision in the anterior or posterior layer of the broad ligament and enucleating the cyst, and this usually does not affect the blood supply of the adjacent ovary. The diagnosis: they are usually asymptomatic, but may sometimes cause lower abdominal pain or discomfort if they are unusually large. But the majority of cases are accidentally discovered during ultrasound examination or at the time of surgery. Ultrasound, of course, is very helpful because you find a simple, clear cyst which is very separate from the ovary. You can see from this ultrasound scan, you can see this is the ovary here, this is the left ovary, and this is a unilocular clear cyst, and clearly you can see there is no communication between the cyst and the ovary, so this is a parovarian cyst. The treatment is usually by surgical excision if it is causing pain and discomfort for the patient, and as we said before, it is by enucleation of the parovarian cyst, and the cavity left is obliterated by sutures, and complete hemostasis is done in order to prevent accumulation of blood between the two layers of a broad ligament and hematoma formation. Neoplastic ovarian masses, these are classified into pathological classification, or B, clinical classification, or C, histogenic classification. And the histogenic classification depends upon the origin of the cyst. If they arise from the surface epithelium, these are known as epithelial tumors. If they arise from the ovarian germ cells, these are known as germ cell tumors, or from the ovarian stroma itself, these are known as sex-cord stromal cell tumors. You can see here from this schematic diagram, these are the ovarian tumors and the site of origin. if they arise from the surface epithelium, these are known as surface epithelial tumors, and these gives origin to the epithelial types of tumors. If they arise from the germ cells, these are known as the germ cell tumors, or if they arise from the stroma in between these germ cells, these are known as the sex-called stromal tumors, or sometimes you have metastatic tumors coming from other parts of the body. The epithelial tumors of the ovary, these are tumors originating from the surface epithelium, and these are the most common. These are classified into serous cystadenomas, mucinous cystadenomas, endometrioid tumors, and Brenner tumors. The germ cell tumors, these tumors originate from the potent germ cells that may show either differentiation into embryonic tissue, such as giving rise to teratomas, or differentiation into extra-embryonic tissue, resulting in choriocarcinomas or yolk cell tumor, or no differentiation whatsoever of a germ cell tumor, resulting in dysgerminoma. So depending on what line of differentiation happens, you get a different type of tumor. The sex-called stromal tumors, these are the least common ovarian tumors. They originate from the two gonadal elements, either the primitive sex cords or the stroma of the gonad. The primitive sex cords will give rise to granulosa cell tumors or androblastomas, or the stroma of the gonad will give rise to fibromas and thecomas. So what complications can happen to benign ovarian neoplasm? They may undergo torsion or hemorrhage, rupture or infection, incarceration, or malignant transformation. The clinical picture will depend upon if the cyst is complicated or not. The majority of cases are asymptomatic. If they are very large, the patient may complain of abdominal swelling, such as in cases of mucinous cystadenomas. Menstrual disorders are common in tumors that are functional, such as granulosa cell tumors, which produce estrogen, and these may cause periods of amenorrhea followed by menorrhagia, or postmenopausal hemorrhage if they develop in menopausal women, or precocious puberty if they develop before puberty. Pressure symptoms if the cyst is incarcerated between the uterus and the bladder or rectum, resulting in frequency or dyschezia, frequency of micturition or dyschezia, or lower abdominal pain if they become complicated. Signs. Generally, you find that if the cyst is very large, you find a large pelvic abdominal swelling. If they're not very large, they can be detected by manual examination. The diagnosis is mainly based on clinical examination, but we usually rely on imaging modalities, especially ultrasonography, CT, and MRI. Tumor markers are also very helpful if we suspect that the mass or the cyst is malignant in nature. The treatment of benign ovarian neoplasm will depend upon the pathology. You can do either ovarian cystectomy, oophorectomy, or panhysterectomy. Ovarian hysterectomy is usually reserved for small benign cysts, while oophorectomy can be performed for larger but also benign cysts, while panhysterectomy can be done for patients that have completed their family if they have associated pathology, or if we suspect that there is a malignant nature underlying the cyst, then it is better to do a panhysterectomy. Thank you very much.